very much. At the outset, I'd like to thank the organizers of MAPICON, in particular Dr. Vitull, Professor D.K. Singh, Dr. Rajiv, for inviting me for this talk over here. So we had an emotional session with Dr. Neeraj Nagpal, and we had an absolute stunning session with Dr. Ashwini. Not that I've been into the court for any case of mine, but as the medical superintendent for about 15 years in DMC, quite a few litigations which take place, and I could see the relevance of the points that he was talking about. Well, those are all in anticipation. I hope and pray that none of you has to go to the court. But the topic that I'm going to talk about is that you have to be involving yourself, because diabesity, as the term goes, is a combination of diabetes and obesity. When we read literature, it says it's a new term. It's not new. It's been there since the 1970s, so it's almost 50 years that this term was coined by AIIMS et al. When they found that the correlation between the two subjects, that is diabetes and obesity, is more important than each one on its own. We see that almost 80 crore people in this world are living with obesity. The childhood obesity is expected to increase to 25 crores by the year 2030. The estimated health expenditure for managing obesity-related conditions is estimated to be $1 trillion by the year 2025. What exactly is the trigger for diabesity? Well, it's a combination of physiological and obesogenic environment. Various biological factors and lifestyle factors are responsible for obesity. The thrifty gene hypothesis, genetic predisposition, all of these lead on to endocrine alterations, slow metabolism and excessive intake, whereas economic, socio-cultural factors and an individual's psychology contributes to lifestyle factors which lead on to physical inactivity, unhealthy eating habits and malnutrition. Together they contribute towards obesity. Central obesity, insulin resistance, hyperlipidemia and hypertension are a part of the metabolic syndrome, and if obesity is associated with type 2 diabetes, various micro and vascular events, the nephropathy, ophthalmological complications and other disorders combined, they lead on to an increased cardiovascular risk. The primary mechanism is the adipocyte injury, which would tend to occur more in the obese individuals, leading to release of various interleukins and TNF-alpha, causing local and systemic inflammation and lower adiponectin secretion. Along with it, long-term high-fat diet intake and reduced heterogeneity in the gut microbiome, because there's a lot of the gut microbiota which is now coming up in various diseases, and diabetes is also one of them. So all of them, this is the molecular pathophysiology as far as diabetes is concerned. Why are we worried about it? Because there are a lot of comorbidities which are associated with it, various cardiovascular disorders. Initially it was NASH and now it is MASH, because it's the metabolism which is probably responsible for this steatoliver disease, the related kidney disease, and obstructive sleep apnea, which tends to be more in obese individuals. The mechanisms of cardiovascular injury include cardiac steatosis, the endothelial damage, heart failure, both of which get exacerbated by dyslipidemia, a higher coronary artery calcium score, the mitochondrial dysfunction, cardiac oxidative stress, poor utilization of energy substrates, all of them associated with the dysfunction in the cardiac muscle contraction. As far as metabolism-associated liver disease is concerned, it may be one of the early end organ complications of diabetes. We become more wiser as far as the subject is concerned. because the number of ultrasounds being done has become much more than what we used to see many years back. Along with it, the fibroscan has come in, so the pickup rate for MASH is much more than what it was maybe 5-10 years back. So the presence of diabetes increases the risk of significant hepatic fibrosis. And there is an increased risk of hepatocellular carcinoma even in the absence of cirrhosis. And all of this is associated with a significant cardiovascular morbidity. Various mechanisms affect the kidneys. It's the podocyte damage, the glomerulosclerosis, the albuminuria. And there is now a theory that the proximal tubule cells have a role in nutrient regulation, and that's wherein some of the medications like SGLT2 inhibitors come in and have a renoprotective effect. The amount of glucose, fatty acids and amino acids which are present in the proximal tubule due to diabesity will cause dysregulation in the relevant pathways. As far as obstructive sleep apnea is concerned, so both of them are interdependent. Directly from the weight, the narrowed airway and the mechanical load, and indirectly the hyperglycemia, hyperinsulinemia and leptin resistance. It promotes obstructive sleep apnea, which causes intermittent hypoxia and fragmentation of your sleep, which further aggravates obesity and the type 2 diabetes. So, keeping all this in mind and knowing that all of your vital organs are at stake, it's important that we take up steps to manage diabetes. Lifestyle modification remains the cornerstone, the most important thing that one would like to do. We need to frame guidelines for exercising. We need to tell them to our patients. An exercise of 150 to 175 minutes per week is recommended. Now we have to take a call whether we are giving this exercise tip to maintain your health, or we are giving it to lose weight, or we are giving it to control your diabetes. Because you need to be vigorous, having vigorous walking. And what would you term as vigorous walking? It would be something like 300 minutes per week of an exercise, and at a speed of around 5 to 6 kilometers per hour. That is something which would help in losing weight. Less than that would just help you in maintaining your health. So exercise helps in reducing the lipid oxidation, controlling glucose and hepatic steatosis. Dietary modifications are important. We need to set a calorie goal of 1200 to 1800 calories per day. And remember that less than 30% of this should come from fat and more than 15% from proteins. A Mediterranean style diet is something which is important and which is recommended. It would contain daily servings of whole grain, bread, beans, nuts, fruits and vegetables. The choice of oil would be olive oil. You can have fish and seafood a few times per week. You could have eggs, cheese, poultry, yogurt, maybe daily, maybe once a week. But meats and sweets are going to be very cautious, just maybe once a month or in very small amounts. This diet, it helps in reducing cardiovascular risk in diabetes patients. It's proven. It modulates the gut microbiota and hence alters the neurotransmitter pathways of satiety and insulin sensitivity. A weight loss of around 15 kg can induce remission of type 2 diabetes in 70% of the individuals. It's difficult and it's challenging, but you need to set up realistic stepwise targets, and sustained weight loss is important. Smaller degrees of weight loss, maybe about 5 kgs, would decrease the fasting blood glucose and it would improve the insulin sensing. A combined approach of diet and exercise is the recommended one to achieve the best possible outcome. This was the Look Ahead trial, and in it they had two arms. One group was in which there was an intensive lifestyle intervention, in which there was a dietary advice plus intensive physical activity which was given. They recorded at least 7% weight loss which was induced and it was sustained. In the other group, where there was just a screening and they were just educated about the diabetes control, they found that there was greater reduction of weight, waist circumference, and HbA1c, and better physical fitness in the intervention group. This trial was not concluded. It was stopped after about 9.5 years because they found that their endpoint, which was designed as the cardiovascular outcomes, there was no difference in the groups coming, and there was a fertility in the trial. But despite no difference in the event rates, the intensive lifestyle interventions resulted in improvements to risk factors and side effects. It raised the quality of life at a lower cost, and although it was negative in its primary outcome, it was positive in many other aspects of diabetes morbidity. The concept of intermittent fasting, something more which has become a fad with the youth than with the elderly. We have periods of intermittent fasting, and there could be various ways in which intermittent fasting is practiced. You can have 5 days of meals, 2 days of fast. You can have an alternate day fasting regimen. You can have a regimen in which it is that your timing of eating is restricted. I mean, it is between 11 o'clock in the morning till 5 o'clock in the evening, and thereafter for the next 18 hours you're keeping yourself fasting. So what happens because of this is that there's a metabolic switch which takes place between the periods of recovery and the periods of intermittent fasting. During periods of fasting, you have increased ketones and mitochondrial stress resistance and antioxidant defenses, whereas during periods of recovery, the primary source of energy is through the increased glucose, and increased insulin takes place during that. So this has shown that if you have a time-restricted eating and if you have a daily calorie restriction, comparing the two groups, there was not much of a statistically significant difference which was observed, whether it was in the blood pressure, whether it was in the lipid profile, or it was in the insulin deposition index. The changes in weight were also not significantly different in the two groups at a 12-month analysis, but result of analysis of the following were consistent with the results of the primary outcome, that is the waist circumference, the body mass index, the body fat, the body lean mass, the blood pressure, and the metabolic risk factors. It has been shown that fasting prolongs life. This is not a myth, this is now a fact. Apart from the lifestyle modification, the pharmacotherapy is important. We have been having various pharmacological agents as far as control of diabetes is concerned, and I'll just touch upon some agents which are used to control obesity. Metformin, insulin, sulfonylureas, and thiazolin. Metformin has been the cornerstone of treating diabetes, and we can use it in patients who are not even diabetic, pre-diabetics, obese individuals. The other three, insulin, sulfonylureas, and thiazolidinediones, these three are associated with weight gain. Therefore, if I'm talking about diabesity, I'm talking about obese individuals, these would be my last drugs of choice. We've got DPP-4 inhibitors, we've got GLP-1 agonists, and we've got SGLT2 inhibitors. Over the last few years, these molecules have been there, and they have really changed the scenario of treating diabetes, especially in obese individuals. Particularly the class of drugs, the SGLT2 inhibitors. If I've got colleagues from cardiology, they're using it in patients who are non-diabetic also for the beneficial cardiac effects that these drugs have. And the GLP-1 receptor agonists. The GLP-1 receptor agonists, they decrease appetite, improve satiety, they stimulate insulin release, reduce the glucagon release, delay the gastric emptying, and they reduce glycogenolysis, and they decrease gluconeogenesis. We've got the short-acting ones and we've got the long-acting ones. Exenatide came in as a short-acting one. Now we've got an extended once-a-week formulation of exenatide also. Liraglutide is available and semaglutide is available. Liraglutide is injectable. Semaglutide initially injectable preparation. Now the oral preparation of semaglutide is also available. All these molecules, the short-acting ones, they have a different mechanism of action, and the long-acting ones, they have a slightly different mechanism of action, but they've all had significant mean weight reduction as well as reduction in the HbA1c. Studies have been done between 1 to 5 years, and all of them have proven their efficacy. The side effects of nausea, vomiting and diarrhea are particularly disturbing, and we need to start off with a lower dose always and then increase the doses. There are concerns about pancreatitis and malignancy. However, there is a modest rise in amylase and lipase. You need to be cautious about using these drugs in patients who've got a pancreatic cancer or who have a history of pancreatitis. I would rather avoid them in those group of patients. But as it is, they don't have any increase in the risk of pancreatic or any malignancy. A word about semaglutide, because that's now available in our country, and it's exhibited significant reduction of up to 5 kgs as seen across various therapies, Pioneer 1, 2, 3, 4, 5, 6 trials. And there's a considerable reduction in the BMI and the waist circumference, and the patients experience body weight reduction within the first 14 weeks of treatment. The SGLT2 inhibitors, again, one very important drug which has been added to the armamentarium, and it's being used to treat both diabetes as well as obesity. The mechanism includes glycosuria. It causes sodium diuresis, free water excretion, which helps in improving the ejection fraction and the renal perfusion. It increases glucagon to the insulin ratio. Both of this leads to reduced effective circulatory volume and causes weight loss. Canagliflozin has been the most extensively studied molecule out of all of these. DAPA, EMPA, ertugliflozin, and these have also been available. Primarily, dapagliflozin is being used in our country, and all of them have shown efficacy in both reduction of weight as well as the A1C reduction. Urinary tract infection remains one important side effect that one has to be cautious. In fact, you should be counseling all your patients when you put them onto SGLT2 inhibitors that in case you contract a urinary tract infection or a genital infection, a genital candidiasis, be sure to inform your doctor, because sometimes patients don't talk about it. They think that it's just a part of your diabetes. And primarily this is because of the excretion of glucose that occurs through the urinary tract. But yes, improvement in renal and cardiovascular functions in addition to favorable effects on diabetes make these one of the preferred agents. Just a summary about these, I've talked about metformin. It's cheap, effective, does not cause any hypoglycemia, has got a long-term safety profile. GLP-1 agonists, again, hypoglycemia is not a major concern, but weight loss is definite and it's helpful. DPP-4 inhibitors, again, no concerns of hypoglycemia. A minor weight loss might take place, but if they're used along with metformin, they are more effective in reducing weight. SGLT2 inhibitors, again, the hypoglycemia is rare. Sulfonylureas, if I have to use, I prefer to use gliclazide because the chances of hypoglycemia are much less with it. But yes, they are cheap and they would remain one of the drugs to treat diabetes because everybody can't afford to take DPP-4 inhibitors and SGLT2 inhibitors. These are some medications which are approved for weight loss. I will just skip it. Yes, a word about bariatric procedures. The metabolic changes which are involved after a bariatric procedure is that it causes decreased appetite, alters food preferences, increases insulin sensitivity, decreases the lipid content, decreases the glucose output, causes a decrease in the adipocyte site, decreased leptins and decreased pro-inflammatory cytokines, increases the GLP-1, increased bile acids, improves the intestinal barrier, changes in the gut microbiota. I'll talk about the gut microbiota, a lot of it is being described now. Increases insulin sensitivity and increases the gastric emptying as well as the ghrelin. We've got various procedures. You can have an intragastric balloon. It's a space-occupying subject, and around 60% of the food remains in the stomach for about 2 hours after ingestion. The advantage is that it's an outpatient department procedure. It's non-surgical, less morbidity and mortality. It's potentially reversible. You just can remove the balloon if the patient doesn't tolerate it. The disadvantage is that it's approved for 6 months only and the weight loss is evident for the first few months only, and you tend not to have a sustained weight loss. Endoscopic sleeve gastroplasty and pose, that is primary obesity surgery of endoluminal. These are other procedures which can be done endoscopically. So I had previous two speakers who are both gastroenterologists and they are dabbling into the legal thing. I'm sure that most of the gastroenterologists are going to take over the endocrinology job also with some more procedures that I'm going to describe. The duodenal mucosal resurfacing, the Revita 2 feasibility trial, this is about 4 years back. It describes the safety and efficacy of hydrothermal duodenal mucosal resurfacing in patients with type 2 diabetes. And if they found that it's safe and it exerts beneficial disease-modifying metabolic effects in type 2 diabetes with or without non-alcoholic liver disease, particularly in patients who have a high fasting plasma glucose. Apart from this resurfacing technique, there are other modalities being studied about which there are no evident data as of now. But yes, the classical Roux-en-Y bypass surgery in bariatrics is something which is one of the choices, especially in the morbidly obese patients, and the lap band is the other conventionally performed bariatric surgery. So if I was to position the therapeutic agents in the management of diabesity, the first line would be lifestyle management with metformin. Can't attain the target A1C, I'll add a GLP-1 analog or an SGLT2 inhibitor or a DPP4 or maybe a sulfonylureas with metformin. I can consider adding duodenal mucosal remodeling at all the 3 steps. The one on the right side shows where you can consider this. So it's not something which is absolutely the end step. Yes, bariatric surgery would be offered only if I cannot attain the adequate weight loss and the blood sugar levels despite using my OHAs, lifestyle management as well as insulin. So in case of deterioration of metabolic health, hypoglycemia, weight gain, increased insulin resistance, despite these agents and insulin, we can consider metabolic surgery. If surgery is not an option, then we can continue with a combination of oral and injectable glucose loading medications. So duodenal mucosal remodeling or resurfacing is a modality which is probably going to be a procedure which is going to be quite common in the coming future. As far as the new targets in the management of diabetes are concerned, we are all aware about leptin sensitizers, ghrelin modulation, the exogenous GDF-15 administration and the amylin analogs. A word about gut microbiota dysbiosis. The manipulation of the gut microbiota takes place because of so many factors: your diet, your antibiotics, the use of pre and probiotics, the fecal microbiota transplantation. So all of these things do manipulate the gut microbiota. The Western diet pattern, which is high in ultra-processed foods, it's abundant in refined components, has sugar, sweeteners, high-fat diet, it's low in plant-based foods. It causes glucose intolerance, insulin resistance, and gut dysbiosis. It also leads to endotoxemia and low-grade chronic inflammation. It increases the ratio of firmicutes to bacteroides. Now, this is harmful for the body. On the other hand, the Mediterranean diet, which is rich in vegetables, fruits, fiber, plant-based compounds, and PUFA, and it's lower in unhealthy fats and refined carbohydrates, it has prebiotic effects like correcting dysbiosis, immunomodulation, energy homeostasis, short-chain fatty acid production, and it reduces endotoxemia, improves insulin sensitivity, causes glucose homeostasis, and improves other metabolic parameters. So there is a role as far as the gut is concerned in treating our diabetes and maintaining our health. We are all aware about fecal microbiota transplant, which is being used in patients with C. difficile infections. We at DMC have been doing a lot of, Dr. Ajit Sood has done a lot of research of using it in inflammatory bowel disease. And there is a role being described as far as diabetes is concerned. It would decrease the tissue insulin, it would decrease the islet cell damage, it would improve the immune function, and it would decrease the low-grade inflammation. As far as some trials are concerned, the fecal microbiota transplantation has ameliorated type 2 diabetes via metabolic remodeling of the gut microbiota in mice. These studies have been published, as well as it has reversed insulin resistance in type 2 diabetes. So prevention is important. That is the cornerstone, and we have a sad current state of affairs. We exercise in front of the TV, we listen but we don't follow. And I'm sure that families who don't have an Xbox or the OTT platform are much better off. Yes, we talk about the great Indian diet. If I was to say, it does have a similarity with the Mediterranean diet. We have a lot of stress upon vegetables, we have a lot of stress upon the pulses, the cereals, the dairy products that we eat by good, I guess. We are still living a fake diet because India is the second biggest manufacturer of sugary beverages globally. That's been published in the Lancet. The per capita soft drink consumption to be almost double to 84 bottles a year by 2021. That was one of the studies in the Economic Times. It's the new fast food destination. The quick service restaurant chains business is expected to grow 8-fold at a compound annual growth rate of around 27%. So there is a weight problem. As of now, 1 out of every 4 persons is obese, and there is an urban-rural divide which is there. Globally, 1 in 10 obese children by 2030 would be from India. The prevalence is much going to be higher. And if you see the cost, how it affects the economy, in 2019, 17.4% of overweight and obesity prevalence in India, and it's projected to be around 64.5% by the year 2060. So we all have to make an effort. We have to try to lose weight, we have to exercise, we have to have a balanced diet, stop smoking, quit the sedentary lifestyle, drink more water, quit alcohol, take more fiber, stop the fast food, split your meals, and all of this is going to help us lose weight and maintain a good, healthy lifestyle. We cannot become what we want by remaining what we are. Let's change for a good. Thank you for your kind attention.
Thank you, sir. This is an announcement for Dr. Sanjeev Chugh. We have your phone at the backstage, kindly collected from us. So the next talk will be given by Dr. Bhagwan Singh, President of AIIMS Punjab and from Patiala, and he will have a heart-to-heart talk with doctors.